So good questions I got during the break. A lot of things. They were asking about my outcome assessment forms. Mine are integrated. My forms are integrated with my EHR. There's some good EHRs. There's some not so good EHRs. You can buy, again, for the outcome assessment forms, you can buy standalone programs too. So, I think Christensen's program is $400 or $500, and you probably pay a yearly little resubscription fee or license fee. But for $400 or $500, that's an easy cost to improve the quality of your notes that way. So, I have Medic Fusion. I know that Dr. Binder uses ChiroTouch. PayDC is one of the other EHRs I heard. What else do you have? Smart Cloud. That's with Future Health ChiroTouch. Yep. You like a web-based system? Yep, me too. Me too. What else? Other EHRs that you really love? Future Health. Yeah, that's Smart Cloud now. Yeah, that's that integrated. Okay. The bottom line about EHRs is you want to look at the technology. And again, you've got server-based, you've got web-based technology. I was on a call, what's today, Saturday, yesterday morning on Meaningful Use 2. We'll be doing some webinars on Meaningful Use 2. It's actually, this is going to be exciting. It's gone down, they've dropped it down to 10 measures for chiropractic. And out of the 10 measures, probably only you'll need to achieve 2 or 3. The rest of them you'll be exempt for Meaningful Use 2. So it's getting easier. But again, the EHRs are very helpful, leveraging that technology to get this information in and help more patients in a more significant way, I think. And I'm not, believe it or not, I'm not a detail-oriented person, but what I am is I'm a systems-based person because I want to have everything run smoothly, and so getting all your notes, getting your EHRs, or getting your forms if you're doing a paper office, and having it congruent and consistent with the message that we have here today is what you want to do. So those systems are very helpful. Okay? All right. Any questions about outcome assessments, anything we've talked about? I know you're excited to get into compliance or compliance, so let's go ahead and do that. Okay? Yes? Well, not all of them have that capability to do that. The question is, if you have a web-based system, do you back it up yourself? That's their responsibility, but I'll speak from experience. Make sure you understand their protocols and their security measures. And again, they should have that documented on how they back up your information, and you should be able to have that document in your compliance manual, and that's what I'd ask if you've got a web-based system. Do you want to add to that?
Just another point to that, we, with respect to systems that are backed up on the cloud, we've had through the years, particularly in the last couple of years, and honestly I can't remember which programs use cloud-based backups, but as Dr. Sharp said, systems do crash, and of course it can be your biggest nightmare. And what we have seen is the doctor won't be initially concerned because they understand that they have backups and it's cloud-based. But what we have seen that's concerning, and maybe this will be a helpful tip, is that while the data is backed up, it is not in a format that's readily readable by you. So if you are looking at a system, or if you have a current system that's backed up in the cloud, I would encourage you to find out if you have a crash and you need that data, what format is it in? For example, one of our doctors just a few months ago had just a meltdown. I mean, the system, I don't know what happened to the computers, but at any rate, she had, I thought, done a good job on her homework, trying to make sure that initially that everything was backed up, but the manner in which the data was stored was not, she couldn't read it. It was, I think, in a comma delimited, actually I'm out of my element here, but it was in a format, she had to pay somebody $20,000 to get it to where it was readable, and it took 9 weeks to get it done. Well, that's not what we want, right? So I'm just suggesting that if you do have it, you might want to add to your list of things to do to find out how, and if they can provide it to you in a usable form.
Yeah, go ahead. Let's start back here. Go ahead.
Multiple locations to try to safeguard against that exact same thing.
Yeah, you know what? They all do, but at the end of the day, it's a server that's backing up information in the cloud. You need to make sure that, because they should have documentation that explains how that's done.
Okay.
So.
And again, not just if it's wonderful, if it's backed up in several places, but if it's in a format that's going to take
Right.
you more than a week to get, ideally you want to back up in 2 or 3 days. If it's in a format that you can't use until an IT group turns it into readable data, it can, create a nightmare for you.
That doesn't make sense. Yes.
I was just going to say, from an IT standpoint, any other IT professional that I've talked to, as far as the engineers and that, have always recommended that you should always just invest into hard drive. That is the best thing that you can do to back up all of your data, because you want that physical standpoint on your, you can hook it right up to your computer to auto set to back up your data, even if you have a cloud-based system, because you never know when those systems may go down.
Right.
Because those things do happen, and then that way you'll have it right away in your practice.
There you go. What is more likely than a cloud-based system going down is your server in your office going down, exponentially more. So whether it's a cloud-based system or a server-based system in your office, I would concur with the doctor over here, is just that you need to have a very significant backdown. And if you've done high-tech, there's a security risk analysis that you do, and it includes explaining how you're backing up your data. So make sure that you're doing it well. I mean, it's so easy to do mirror hard drives and then do off-site hard drives or backups as well. I mean, again, like I said, we have no filing cabinets in our office, so everything is electronically stored, but it's stored in 3 or 4 different ways. So again, it's pretty easy to do. In this day and age, with cloud-based technologies, it's just a matter of if your hard drive goes down in your office, you throw that away, bring another one, log into the internet, and move on. So, but those of you that are using server-based, you want to make sure that that is done properly. Invest the money, okay, to have good hardware. All right, so those are good things. There's one other thing about, again, if you're looking at EHR, just make sure you take the time to talk with some of the doctors that are using it. A salesperson is not a good resource for understanding the performances, the strengths and weaknesses, because they all have strengths and weaknesses. So some are better for some styles of practice than others. So make sure you're spending some time to really do some research, if you haven't already, okay?
And to add just a quick point to that, most of the new EHR systems do provide for the production, most of the new systems will allow you to download the HIPAA 835 payment file. That's the file. How many of you know what I'm talking about? How many of you do auto payment posting? So to digress a minute, if you're not doing that, you really should look into it. How many of you are manually posting your H&S EOBs to your patient accounts? You don't have to do that. The 835 file is a HIPAA compliant file that links, it's uploaded, let me back up, on every bulk provider check cut date from H&S, the 10th, 20th, and last business day. Y'all know, I believe, that we upload your EOBs to our website. We also upload the HIPAA 835 file for that same time period. And if you have a good EHR system, that EHR file includes all of the EOB information, and it interfaces with your software and automatically posts the payments to your patient's accounts. You push a button and you're done. And it is just so efficient. So if you are looking, most of the new programs, because this is such an efficient way to do it, in medicine, the use of 835s have been around for 15 years
Right.
or longer. And it was, I couldn't believe when I came on board at H&S that our doctors were still manually having to post EOBs. That's why we tried to make this available to you. So if you're looking at a new system, make sure that it can do that for you, because it's just a wonderful, wonderful service. Most of them do, but we did just have a doctor that spent some money buying a new one and didn't know until after he bought it that it was kind of an oddball one, and it doesn't do it.
Do you know Smart Cloud or Future Health?
Future
does
Health,
that?
absolutely it does.
Okay.
Yeah.
Yeah. The HIPAA 835, yeah. You just need to tell them that you want the ability to download an 835 file. You can always call our IT department at H&S. This isn't something, we already produce the file and give it to you. Unfortunately, your software vendor has to help you set up the interface, because it's not that we don't want to do it. We can't get into your software. But it's not a big deal to do.
That's great. Good, but I'm going to tell you, in staff, you know, this is, I find a lot, staff is hesitant to download an H35 file because you think it's all going to get lost. You lose all of your control. That's not it at all. You actually download it, you go in and recheck it, make sure everything's good. But staff, this is what I would encourage you. At the end of the day, what's the most important thing that happens in your practice? Patient care, right? So when you're not taking time, and here we are talking about documentation and billing and so forth, but at the end of the day, again, systems to make sure you have the appropriate amount of time to properly care for your patients. So instead of spending half of a day or hoping you get no new patients for the day or no new patients come in and interrupt you so you can manually input that, you can get this done in less than 5 minutes, get back to caring for your patients. The last thing you want to do is sit there and manually post an H&S check, okay? My only problem with my H&S checks is they're not big enough. I just need more patients, right? That's a joke. Come on now. We need to get you guys woken up. All right, any other questions on that? Good questions, good questions. Well, let's talk about non-compliance. This is a brand new form that came out of the seminar we did a month ago over in Greensboro. So we had a good conversation about non-compliance in our seminar. So the point being is that if your patients are being non-compliant with their care, it becomes non-covered service. So for those patients that come into your office and they come in for twice out of the first 3 visits you schedule in that first week, and then you don't see them to the next week, and they come in for 1 or 2 for that week, and then they're gone for a week, and they come back for 3 visits, and guess what? For some reason, they're not getting well, right? Because they're not following through with the regimen of care. As we say in our practice, if you're compliant and you follow the doctor's recommendations, you're most likely to get well. Those that don't follow the doctor's recommendations never get well. So in that case, how do you manage that in your practice if you've got those patients? So this is a form called the Chiropractic Non-Compliance Form. This can be downloaded. You have it in your packet, I assume, today. And it's on the website. Again, in a Word format, not for you to change it to make it better, although some of you just can't resist making these forms better, but you can customize it for your practice. Put your logo in there, put all that stuff, and then essentially it goes down and it reads as follows. Patient noncompliance is a significant and contributory factor to poor treatment outcomes. We want to get patients well, don't we? And leads to more costly health care as well as potential malpractice claims Accordingly, it is the policy of this office to document non-compliance to treatment recommendations, including but not limited to frequency of treatment recommended in the patient's treatment plan. And additionally, it is the policy of this office that services provided to patients who do not comply with this office treatment plans or treatment recommendations will not be billed to their health care plans. As such, services are not consistent with medically necessary care. Is this strong or what? Okay? And therefore not covered by the plan. This includes but is not limited to patients who do not keep scheduled appointments and or choose to seek care at their discretion and at their convenience. And then it goes through and there's just check-offs, summary of non-compliance, failed to adhere to treatment recommendations. You can kind of read through those. Follow-up actions. Now, this is actually Dr. Binder and I and Ms. Binder went through this and kind of how Dr. Binder uses it, his system in his office, how my system is in my office, and we kind of put this together. So if you're sending letters, faxes, emails, text messages. By the way, how many of you are texting your patients? Okay. Wow, I'm surprised. Okay, that's great. Emails, telephones, and again, you can date. So you can have your staff. The only thing that I would add to this is whoever is filling this out would initial it. So if they put a date, that they would initial that in subsequent attempts and the final action. And then once this was completed, then you essentially just put this in the patient's record.
And just to add to that too, y'all probably know this, but the North Carolina Board of Examiner practice guides clearly state that a patient that does not comply with the treatment plan must be discharged.
Right.
And NCMEC, I think everybody knows who NCMEC is, we have a section in the practice protection plan on risk management, and that information was provided to H&S by NCMEC's attorneys. And there's a whole section about patient noncompliance, and that it absolutely must be documented. You know, if you do end up, heaven forbid, getting sued, and that was maybe part of the issue, if it's not documented, it's going to hurt you. So this is not anything that's mandatory. It came again from discussions during the last seminar that the doctor said it would be helpful if they had some kind of form. So
Great. And it's a very strong form, so I think it's great. Let me ask a question of you. And I have a patient that is a truck driver. He's in town on Mondays, leaves Monday night, and he doesn't come back in town till late Friday afternoon. So his treatment plan is affected by that. It's as compliant as he can be. So in that circumstance, in a special circumstance, how would be the best way to handle that in our notes?
I'm going to defer that to.
Okay.
I would say no differently than any other patient, because you're going to set up goals
Okay.
for that specific situation. Then you're going to measure those goals. And if he keeps hitting those goals, then you keep progressing along with the treatment plan.
Right.
When the goals cease to improve, you're going to be doing nothing other than supporting his situation at that level.
Gotcha.
Therefore, supportive care.
Okay.
And am I right in thinking that the number of visits might not change, rather the length
The
of the
length.
care? Right, because he's obviously going to get better if you can see him 3 times a week, but is that
Sure.
correct?
Yeah, absolutely. Okay. Good. Any other questions on that? This would be a great form to add in on Monday. Okay, in your staff meetings, if you're having staff meetings with your staff on a regular basis, or staff, if your doctor's not here, don't you see how this would be nice just to document everything and put it in there? Because at this point, up to this point, we did have some record of phone calls and certainly of missed appointments because they don't show up on the schedule, but no explanation. Yes?
That we keep this on file for our own protection, but is it also something that you would present to the patient so that they understand that if they don't comply, that are they signing this form, or do the patients even know about this, so that they understand that if they're not compliant, then we're not going to bill the insurance company?
Okay.
Well, I think that's really up to you. I'm not sure who asked that question.
Right over here.
Thank you. I think that's up to the physician. Our intent was just to give you a tool to document it, and where Steve or Kevin might think differently. In my mind, this is not something you're going to mess with if the patient misses one appointment, you know, or doesn't show or something. It's when you are unable to meet treatment goals timely, and it's resulting in a lot more visits as a result of their noncompliance. It would benefit you to have a documentation of that, and I think in some cases it would certainly benefit the patient to understand that as a participating provider with Blue Cross, you have to meet you can only bill care that's medically necessary, and because they're not complying, you can't bill it. And the Board of Examiners, excuse me, so your licensing board.
Now, many of you probably have kind of a welcome to the office letter or a packet that has forms and graphs and things like that. I was kind of toying with the possibility of just adding this to that welcome letter. And, you know, not the entire form, but kind of out of the, again, that's why it's great to have it in a Word format. You can copy and paste it, maybe make a few little changes. Right. Right. But I think it's great to set expectations for your patients. And we do that often verbally, but this puts it in writing, and if they read through that, it is likely that they're going to be better patients. Again, you know, the things that slow our progress down often are patients' compliance and keeping up with things. So we want to, at the end of the day, what are the two things you value? Your patient's health and your reputation, right? So if your patients are following through with your recommendations, both things are preserved, and that's what we want to see.
Years since I had braces, but even that long ago, any of you that had braces or had children with braces know that the monthly payments go on and on and on as long as you're in braces. And my orthodontist required that I sign something. I don't remember the words, but
Sure.
it was just like this, you know, that it wasn't related to billing for insurance because it
Right.
wasn't covered, but that it was certainly going to impact the cost of the care, and they expected us to fully comply, blah, blah, blah.
That's great. So, good question, and you know, think through that. Think over that through the weekend, and again, I would present this to your staff. Docs, another little thing with this little side note on this, a form like this that really is going to be a staff-oriented form, I like to engage my staff and get their feedback on it. I certainly have the final answer on it, but it's nice to have your staff be a part of how it's being implemented and how it works in your practice. So, okay? All right, so non-compliance. We don't like to have to use that form. That's the goal, is never have to use that form. But now you have a form to work with. And again, if you think of ideas throughout the course of today's seminar, as you're viewing it later on, if you have questions or suggestions, I mean, I think that's how this program has changed over the years based on recommendations and needs of the providers. So let's talk about informed consent. Now, you thought non-compliance was exciting. Informed consent is even more exciting, all right? That was another joke. Okay, we need to get some energy going here. So, we are legally and ethically obligated to obtain informed consent from our patients prior to initiating treatment. Consent cannot be considered informed unless, at a minimum, the physician orally explains the risks associated with the proposed course of treatment and answers any questions the patient may have, and obtains the patient's permission to treat. So the discussion should include risk and benefits of treatment, alternatives to treatment, and the discussion should include a review of likely outcomes if the treatment is withheld or refused. You know, very interesting. And if the patient is a minor or an incompetent adult, the informed consent discussion must include the patient's parent or legal guardian as well. Okay? So, during the ongoing treatment, if there's a new condition or an added condition, then you would need to review those contraindications again. So providers should obtain a new informed consent when presented with a new condition that was not addressed when previous informed consent was obtained. So for an example, lumbar manipulation conditions have different groups of risk of injury than cervical manipulation, and a 70-year-old may have different risks than a 20-year-old, yada, yada. So this is the thing. I find this to be very difficult to remember to do in my practice, right? I'm cranking along, I'm seeing patients, they come in with a new condition. Man, I've got that sharp guy wants me to do, you know, a new exam, new x-rays, new diagnoses. He wants me to do an extra treatment or update my treatment plan. And now he wants me to get an informed consent. Again, this is just, it's not a matter of should you do it, you have to do it. So you need to add this into your regimen of things to do. And this is the other thing that I would talk about on Mondays. How do you do that easily in your office? If you've got to leave your treatment room, go find a form, come back and do that. That slows the process down. So how you do that should be discussed so that system should be ready. Likelihood is if you have a system in place, then you'll do it with much more consistency and with much more ease. Okay? While a form cannot replace the required face-to-face discussion between physicians and patients, H&S requires written evidence in the clinical record that the provider obtained informed consent from each patient prior to initiating treatment. And the clinical record must include the signed and dated H&S informed consent form or similar form. The H&S form is available on the website in the form section. So we just use that. It just makes it simple. H&S got that from NCMEC, and again, it just makes it simple and easy to get that done. So we have that form in our office. Yeah.
Thank you. The first one, I'm not sure if I missed it. Did you say that if we have a patient who is already has been a patient in our office and comes back for another condition, they still need to sign an informed consent, or can we just have it in written in the file?
Right. I would do both.
Both?
I would, again, have them sign the form because it's got a different set of exclusions or contraindications, and that's why...
Right.
Yeah,
Normally, I mean, what I have done so far is that if I have a patient that I have treated in the past who comes back, I put on my note that, you know, that I have something written in my notes stating that I discuss the treatment plan with the patient as well as the potential side effect, and the patient agrees with that and is willing to move forward. But I don't have them. I have them sign a form when they come in as a new patient.
Initially.
But do I need to have them re-sign the form again? Yeah.
You would,
Okay.
especially it's a whole new set of again, contraindications, risk factors, and so forth. So she's got to reboot that. So you just got to be able to do both. Put that in the note and have them sign a new form.
What if we have an additional complaint in the middle of a treatment?
I would do the same thing.
Also with a signature on it?
Yes, yes.
Okay.
So this thing, you know,
If the complaint's related to a different condition.
Right.
right. So if you're adjusting somebody low back for the low back and leg pain, and then all of a sudden they come in with an elbow issue, I mean, that's a very short discussion. You know, there are not a lot of risk factors for the elbow.
Right.
Wouldn't you agree? So some of this is, I mean, we're talking about a 30 to 45-second discussion going through that with the patient. Maybe it'll take longer for more complex situations. But yeah, you'd
Right.
have to have
No, I
both
don't have a
oral
problem
and
with the
written.
discussion. That's the easy part. I
Yeah,
mean,
the
I
written.
wasn't sure if I needed to, because the form is the same. I mean, the informed consent that I have is the same. So,
You just write that condition on the form. You do write conditions on the forms. You customize the form. There's a place to actually write the condition. So that's you just write the updated condition.
Okay.
I wonder if it would be sufficient to add the condition, put another date on there, and have the patient re-sign and redate the same form. That might be an easier way to do it.
And let me take just a minute to talk about this. Many of you have been to these seminars before, and so I'm sure you've heard me say this. As Dr. Sharp said, the Board of Examiners does not require this signed form. Your board does require that you obtain informed consent, that you have the question and answer discussion, advise them of the risks, et cetera. The only reason that we, and this was from our advisory boards, doctors in our network, decided to require the form, was to help protect you. As you all know, we credential you all So H&S is aware every time there's a malpractice suit filed. And unfortunately, it happens way, way too often. And so we saw this requirement as a way to help you cover your practice, okay? And I'm not an attorney, but from NCMEC's perspective, the most important thing is that there is something in your records that clearly indicates that you explain the risks associated with whatever the condition, the treatment, the condition for which you're providing treatment, and that you clearly obtained the patient's consent to treat. Okay, that's what matters the most. H&S is not going to fuss at you or kick you out of the network if we look at your records and you haven't obtained informed consent. Your board expects you to, and certainly your malpractice carrier expects you to. So I wanted to help put that in perspective a little bit to help answer your question. If your documentation is clear, I think one question NCMEC might have is with what you're doing, and I'm just speculating, is where is the evidence that the patient agreed to have you,
Initiate care.
where
Yeah.
the patient gave you consent to treat,
Right.
you know? So I think there is some real protection by having something signed. But again,
When you're looking at the chronology of your record, the new form with the new date that coincides with that new condition is going to be what she just explained. That will cover you, that you had that discussion on that day because the conditions changed.
Right.
So that would be the way to do it. Whether it's the same form or not is regardless.
Okay.
You know, it's the date and the chronology of when you did it.
Gotcha.
But you
Okay.
still would suggest, by the time they come up to the front, that maybe the front desk has something for them to sign that there's a new condition.
Right, the question is, should we have have that form up at the front desk so when they come up the front desk to sign it? Well, either you have it at the front desk or the doctor has that, because oftentimes the doctor doesn't know, in this case, that he's going to have a new condition on that day. So it'd be nice for him to have access to the forms in his treatment room. He's able to pull that up. They can sign off on that, walk the patient, or goes up with the patient file, however you do it in your office, and have that have the patient sign it in front of you. And maybe you don't even send it up with the patient. You just take it up to the front desk later on, and not even engage the staff at all.
Okay.
So,
The second question that I had was for the 17 years old who drives, who is the son or the daughter of a patient, and the parent just send them in because, you know, they have an issue with their neck and they just show up without the parents there.
right.
How do you handle that? I mean, you send them back home? Do you?
I'm sorry, but I know specifically from NCMEC's attorney, a minor cannot consent. A minor cannot. Now, I would toss this back at you guys in
Thanks.
the field.
Thanks a lot for sending it back to us. So this is how I handle it in my office, of course. What we'll do is, in that situation, is we'll do the assessment, and then I'll have, but I won't treat him. And then I'll have my staff call and say, we've got a new condition with the patient. We need to have an updated informed consent. Oftentimes in this day and age, we can email that back and forth. Occasionally people will have us fax it back and forth, or they'll show up or have us send it home with their child the next day. So that's how we handle it in our office. Okay? Yeah. Right here, you.
Just wanted some clarity from a comment you made, Parker. You mentioned that something happens way too often, and I'm curious whether that's malpractice cases or whether that's offices not acquiring the informed consent.
Good question. No, these are malpractice cases. And, but we do see often that, wait a minute, I won't say often. We see all the malpractice cases that ever affect any of our doctors in either state. We have to. It's part of the credentialing process. And at least some of the time, lack of evidence of obtaining the patient's consent is a significant factor.
And I'm curious with that description, Parker, how often are there malpractice insurance coming across your desk? Are we talking once a month, once a week?
Over here. Okay.
Over here, Parker. How often do you see malpractice cases in North Carolina?
20, 30 times a year, maybe more. Well, and you know, I won't ask for a show of hands, but I know some of you have had suits filed, and remember, lawsuits are nothing but allegations when they're filed. But it's like an IRS audit. You sure as heck don't want to have to go through it, right? You do not want to go through it, and so it certainly can impact your participation in the network. Not just your participation with H&S, but how many of you are par with Blue Cross Blue Medicare? I know most of you are. Did I not say Blue Advantage? Almost everybody in here is. You're par with Aetna. You're par with United. The NCQA, the National Committee for Quality Assurance, establishes the standards for credentialing, and H&S has to meet those standards. And when there is a clinical competency issued as a result of a malpractice, if it indicates, I think that's the best way to say it, a clinical competency issue, you can't stay in the network. Blue Cross won't let you, Aetna won't let you. And or if there's a history of several that are questionable, but there's several, you can't stay in the network. So for a million reasons, we want to help you protect your practice. And you know, obviously, informed consent isn't of itself going to protect you, but it is a significant factor. Real quickly, we had a formal complaint, a quality complaint, investigated by our QUM department. First time we've had one in years. And the patient alleged that she told the doctor she did not want, and by the way, this came to us from Blue Cross Blue Shield's Special Investigation Unit. You don't want Blue Cross, it's SIU, to be looking at you if you can help it. Not because they're bad people, but we don't want that any more than we want the IRS audits. The patient alleged that she had told the doctor that she did not want her neck adjusted, and he did it anyway. And as a result, she had tinnitus and all kinds of things. Now, this wasn't a lawsuit. This was an allegation, but it has to be formally investigated. We requested the records from the doctor, and Dr. Bender and Dr. Armstrong reviewed them, and there was nothing in writing indicating that she said she didn't want it. Now, that doesn't mean she didn't. The doctor could have
Just
not written it down, but I would like to think that the doctor would have done what she said. But at the end of the day, the patient's record included a beautiful informed consent, which also included the statement that the patient agreed to whatever treatment recommendation the doctor made. Okay? So we closed it, said the doctor did nothing wrong. Of course, the patient didn't like that, but all right.
Yeah, and that's a half-cent piece of
I'll
paper.
quickly add some of the facts. Is the patient claimed that she signed something in the record that stated she did not want her cervical spine adjusted, but that was not to be found any record of where she wrote that in her record herself. So there was some discrepancies in what the patient was claiming and what was actually found.
Great. Just a question over here. Nope, we're good? All right. Any other questions? Good. Yes? Yeah, so, you still have to produce some paper. So what we do is we produce that paper, they sign it, we scan it in and shred it. That's how we do it. Right into the record, yeah. Every piece of paper that comes into my office is scanned into the patient's record. So, okay? So with one little exception, like when we get our H&S EOB, we do, rather than put the EOB into every single patient record, we organize our EOBs by dates, and so that just, as long as we can access that, that's good. All right, any other questions? Good. You know, I'd hate to go through a malpractice case because I didn't have an informed consent with the patient or that was being questioned, you know, over the thousands and thousands of patients that you see. So, all right, let's move on from informed consent now that I'm scared to death about seeing a patient on Monday. All right.